Hello students, let us discuss one more module in image-based questions in general surgery. So this is module number 6 and we are going to discuss the case scenarios in upper GI tract. Case number 1, this is 70 years old male presented with progressive dysphagia, foul breath and gurgling in throat. There was history of weight loss and aspiration pneumonia was present. Food particles can be expressed by squeezing the sides of the neck. So these are the three pictures and these are the 6 questions. What is the investigation done in figure 1 and the finding? See, this investigation is a barium swallow and you are seeing clearly this is esophagus and here from the esophagus you are seeing a diverticulum. Okay, what is your diagnosis? Diagnosis is Zenker's diverticulum or pharyngeal pouch or pharyngoesophageal diverticulum. Okay, usually this diverticulum will be on the left side of the neck. The figure 2 here you are seeing this is an upper GI endoscope. This is the esophagus and this is the blind ending diverticulum. So you should not, you have to be very careful while you are doing the upper GI endoscope because otherwise you may perforate this diverticulum. You have to be very careful. And this is showing the upper GI endoscope diverticulum in the, it should be avoided because it's risk of perforation. I told you already. It is indicated only if an esophagogram demonstrate findings consistent with a neoplasia in the diverticulum. Then only you have to do the upper GI endoscope. Otherwise, there is no need to do upper GI endoscope. You can do the barium swallow and you can prove it. And what is the cause or etiology for this diverticulum? It is a pulsant diverticulum or it's a because of intraluminal pressure. Okay, this is a false diverticulum arising at the junction of pharynx and cervical esophagus in the area known as Killian triangle or Killian dehiscence. Two potential causes are number 1, increased hypopharyngeal pressure. That is one thing, accompanied by poor upper esophageal sphincter opening or cricopharyngeal incoordination. That is the cause for the development of this diverticulum. And what are the clinical features? Usually, this is very common in elderly male patients. Patient present with complaints of dysphagia, cervical dysphagia, regurgitation of food recently chewed, halitosis, that is bad breath, and globus sensation in throat, that is foreign body sensation in the throat, and a left-sided neck mass will be there. There is history of loss of weight, but aspiration and pneumonia are infrequent. So what is the treatment for this condition? Treatment is only surgery. There is no, conservative treatment for this. Either you can do open surgery or you can do endoscopic surgery. Open surgery, you can put an incision over the left side of the neck and you can do what is called diverticulectomy with cricopharyngeal myotomy, or you can do diverticulopexy also. This is what you can do in open surgery. In endoscopic myotomy, this you have to use an operating laryngoscope. This is a rigid esophagoscope. Actually, it is used to expose the neck of the diverticulum, and a myotomy is performed using an endoscopic linear stapler. And this procedure is known as Dolman's procedure. This is what you are seeing here. This is the rigid esophagoscope you have to introduce inside, and this is the septum in between the esophagus, and this is the diverticulum. So you have to staple this area so that this septum you have to cut so that the whole thing will become a single cavity. That is the idea. So coming to case number 2, 3-year-old boy was brought by his parents with alleged history of ingestion of a foreign body. On examination, boy was alert to oriented without any respiratory distress. The chest X-ray is shown. Chest X-ray along with the neck. It is what is the finding in figure 1? You are seeing the coin there stuck in the neck itself, that is the upper part of the esophagus itself, it is stuck. And coin is lying where and why you are saying so? Coin is lying in the upper esophagus because I am telling it is lying in the esophagus and not in trachea because we are seeing the flat surface of the coin. If it is in the trachea, you cannot see the flat surface because trachea is an anterior-posterior slit because of the presence of C-shaped tracheal rings. So you can see only the oblique view of the coin and not the flat surface. If you are seeing the flat surface, that means the coin is in the esophagus. Besides that, if it is lying in the trachea, the patient will also have some sort of respiratory distress. That is also not there in this patient. So this is definitely it is lying in the upper esophagus. What are the areas where it can get stuck? Okay, it is in the upper esophageal sphincter, lower esophageal sphincter, and the third area is where the aorta is crossing the arch of aorta here. It's crossing the esophagus. There also it can get stuck. And what is the treatment you are seeing in figure 2? So this is actually one of my cases. So I did an upper GI endoscope immediately because it is stuck in the esophagus. So I did an upper GI endoscope. Okay, I just introduced a foreign body forceps and I removed this coin. So it is a very easy procedure. But in pediatric patient, you have to anesthetize the patient and you have to do it. Otherwise, it's very difficult. And suppose if the coin is already has reached the stomach, you need not do anything. Automatically, spontaneously, that will come out in the fecal stream. Suppose if it is a button cell instead of the coin, then irrespective of where it is, even if it has gone into the stomach or lying anywhere in the small bowel, you should remove it immediately because otherwise, no, that will dissolve and that will break and break. It will burst open, I mean that button cell, and that will erode the intestine or stomach and that will cause perforation. For fear of perforation, button cell immediately, wherever it is, we have to remove it immediately. Okay. So this is case number 3. 30-year-old man presented with worsening dysphagia for liquids to begin with. Regurgitation and chest pain was also there. Barium swallow and esophageal manometry are shown here. So what is the investigation here performed in figure 1? This is again barium swallow, but here you are seeing the classical bird's beak appearance. See, it is a smooth tapering of the esophagus. The proximal esophagus is very much enlarged. This is known as sigmoid esophagus, and it is a smooth tapering. And this is the distal esophagus. Okay, because the sphincter here is not relaxing. What is the radiological appearance and the diagnosis? This is a case of radiological appearance is bird's beak appearance. So the diagnosis is Achalasia cardia, one of the motility disorder in the esophagus. What is the cause of this? It is the most common primary esophageal motility disorder caused by inflammation of mesenteric plexus, leading to fibrosis with decrease and loss of mesenteric ganglion cells. So this is the pathology. So figure 2 is showing what? Yeah, figure 2, okay. This is figure 2, this is esophageal manometry. So you can see there is no peristalsis in the esophagus and pressure in the lower esophageal sphincter is enormously high. That is what you are seeing here. You are not seeing any peristalsis here. See, that is what you are seeing. What is the treatment? Okay, you can use botulinum toxin to provide temporary relief and symptomatic improvement. You can also do pneumatic dilatation, but recurrence can happen within 5 years. The surgical myotomy, that is called the Heller's cardiomyotomy, should be considered if there is failure of the previous non-surgical, both the botulinum toxin and pneumatic dilatation fails, then you can do this surgical procedure. Even it is more suitable for younger patients when there is other coexisting pathology that requiring surgical intervention. You can do this surgical Heller's cardiomyotomy. And the latest recent advance is POEM, that is per-oral endoscopic myotomy. Instead of doing open LS cardiomyotomy, you can do it with endoscope. You can do it with laparoscopy also, LS cardiomyotomy. Yeah, the POEM is the recent novel technique. Coming to case number 4, the 70 years old male presented with progressive dysphagia for solids who underwent neoadjuvant chemoradiotherapy. So describe the abnormal endoscopic finding in picture 1. So this is a upper GI endoscope. You are seeing a cauliflower growth, ulceroproliferative growth, almost occluding the whole lumen of esophagus. What is your diagnosis? Tumor, benign tumor is not common in esophagus, so this should be esophageal carcinoma. What investigation were performed in picture 2 and 3 and what are the findings? In picture 2 and picture 3, this is barium swallow. But unlike the previous one in Achalasia cardia, here you are seeing there is no smooth tapering of the esophagus. Suddenly the esophagus is becoming narrow and this is the narrow esophagus. So this is what is called soldering effect, and this appearance is known as rat tail appearance. Okay, this is a rat tail appearance, and this investigation is endoscopic ultrasound to find out the T stage, the tumor invasion, whether the tumor has invaded only the mucosa or the submucosa or the muscularis. All these things you can make out by doing an endoscopic ultrasound. So which kind of additional investigation would be useful? Endoscopic ultrasound, CT of the thorax and abdomen may be used for staging purpose. You have to do it. Upper 2/3 of esophagus usually squamous cell carcinoma. The lower 1/3 esophagus is usually adenocarcinoma. Okay, and what is the other alternative therapy? You can do radiotherapy, that is super voltage external beam RT, may be curative or palliative to relieve dysphagia. Brachytherapy is another option. Chemotherapy, most of the regimens have 5-fluorouracil with or without leucovorin. Palliative procedures like laser vaporization of the growth and self-expanding metallic stents, that is SEMS, or just intubation with a stent. Anything, all these are palliative procedures, because majority of our patients usually they come very late in an advanced stage. So you cannot do a definitive procedure, you have to do only palliative procedure only you can do. And what do you mean by neoadjuvant therapy and what are its advantages and disadvantages? Treatment with chemotherapy and or radiation to the primary lesion before surgery is called neoadjuvant therapy. Advantages: there is potential downstaging of the tumor, early treatment of micrometastasis, treatment is better tolerated before surgical stress, and verification of tumor sensitivity to this particular therapy. All these are advantages. So what are the disadvantages? Delay in treatment of primary lesion, selection for chemo-resistant cell lines, and potential cause the tissue around the tumor to be inflamed. All these are disadvantages. So treatment, you have to do only excision. You have to do esophagectomy. There are so many types of esophagectomy. Either do esophagogastrectomy or 3-stage gastrectomy or transhiatal esophagectomy. All these things you can do depending upon the stage of the disease and where it is situated. Yeah. This is case number 5. This is an endoscopic view of the esophagus. What can we see in picture A? And how may this present clinically? You are seeing a narrowing and stricture of the esophagus. Patient will present with dysphagia, regurgitation and vomiting. So what is the various causes for this finding? If it is a benign stricture, the cause could be chronic GERD, anastomotic stricture or corrosive injections. Malignant causes is CA esophagus. So what is done here in this picture? What they have done here in the picture B and picture C, and what is picture D? Okay, you have to see insertion of guide wire and subsequent balloon dilatation of the esophagus is done in these pictures. So what are the complications? Early complication, it could be bleeding or perforation. Late complication, again, it may go for narrowing, re-narrowing. So self-expanding metallic stent was introduced in this picture. Okay, here, after dilatation, balloon dilatation, they have introduced a SEMS, self-expanding metallic stent. So case number 6, patient is a 46-year-old man with history of hepatitis C who presented with hematemesis. What is being performed here? Yeah, what is the pathogenesis? Okay. Emergency upper GI endoscopy and banding of esophageal varices with rubber bands is performed here. What is the cause for this pathology? Portal hypertension leading to portosystemic stenting producing esophageal varices. What is the cause for this cirrhosis of the liver? It could be because of alcohol or hepatitis B or C. When the rebleeding will occur, it depends on the size of the varices, directly proportionate to the vessel wall tension. Red wale marking or white nipple sign are telltale evidence of recent bleeding. Severity of the liver disease and persistent alcohol abuse all will produce rebleeding. And what is the initial treatment? So, or pharmacological treatment and endoscopic. The pharmacological treatment is terlipressin and actroprid injection. The moment you know it is esophageal varices, you can start either actroprid or terlipressin. If this cannot control the bleeding, then you can resort either to endoscopic banding or endoscopic injection sclerotherapy. If this is also not effective, then temporarily you can stop the bleeding by using Sengstaken Blackmore tube. Okay, if the pharmacological and endoscopic measures fail, then the balloon tamponade is only temporary. You can use it only for 24 to 48 hours. After that, you have to resort to this transjugular intrahepatic photosystemic stenting or TIPS procedure. Yeah, or you can do instead of tips, you can do some surgical shunt like splenorenal shunt or mesocaval shunt. The splenorenal shunt is known as Warren shunt, or you can do esophageal transection. But nowadays we are not doing portocaval shunt. Okay, what is this? How can we prevent recurrent bleeds? 70% of patients rebleed within first year. You have to give beta blockers to reduce this risk. And you have to do either injection sclerotherapy or banding. That also will reduce the rebleeding incidence. And a patient with variceal bleeding was treated with this tube. What is this tube? This tube is triluminal tube. So this is a Sengstaken Blackmore tube. What is it used for? To temporarily stop the bleeding in esophageal varices. How is it deployed? So you have to put it inside, you have to inflate this stomach balloon with 250 ml of radio opaque material like gastrographene. Then you have to pull it up so that the gastroesophageal junction will be compressed, and then you have to inflate the esophageal balloon also. Okay, so both the balloons, the gastric and esophageal balloons, will occlude the blood vessel and temporarily the bleeding will stop. So you have to use it only for 24 to 48 hours. What precautionary measure you have to take for avoiding complication? So you have to release the esophageal balloon intermittently. So you shouldn't keep it, inflated throughout. Maybe after 2-3 hours, you can deflate it for some time and then you can inflate it. What is the complication? Okay, if you are going to keep it beyond 48 hours, there may be incidence of esophageal perforation. Case number 8. This is a 60-year-old man. He is a known case of stroke, and this procedure was done for this patient. So what you are seeing in this picture, Because the patient is a known case of stroke patient, he is unable to swallow, and that is why they have done a gastrostomy. This is a PEG procedure, percutaneous endoscopic gastrostomy. PEG, or you can do it either this PEG or you can even do by open method. What is its use? It is used for enteral feeding when peroral feeding cannot be carried out due to either mechanical obstruction or neurological cause. Here in our patient, this is neurological cause affecting the swallowing mechanism. What are the complications? This tube can get blocked or it can get dislodged. What you have to do if it is getting dislodged, you have to do replacement. What else apart from this feeding? What else you can do? Because there is no mechanical obstruction. You can put a nasogastric tube and you can feed the or nasovaginal tube, but you can keep these tubes only for 7 to 10 days. After that, if it is a long term, you have to do only either gastrostomy or you can go for jejunostomy tube also. Case number 9, this is a 5 years old boy brought to the hospital for complaints of passing melanic stools on and off for the past 1 week. In spite of repeated blood transfusion, his hemoglobin was only 5 grams. So technetium 99 nuclear scan was done to clinch the diagnosis. Intraop picture was shown here. What can be seen in intraoperative picture in figure 1? This is Meckel's diverticulum in the anti-mesenteric border of the terminal ileum. Okay, it is the remnant of umbilicomesenteric duct or vitellointestinal duct, which connects the yolk sac with the primitive gut in the embryo. Where it is situated, about 2 feet from the ileocecal valve on the anti-mesenteric border of the ileum. So what do you mean by rule of 2? Incidence is 2%. It is 2 times more common in male patient, present before the age of 2 years, 2 inches long, and its location is 2 feet from ileocecal valve. So what are the, how this Meckel's diverticulum can present to us? Occasionally, okay, it may present with intestinal hemorrhage, melena, or it can present as intestinal obstruction because of presence of band, or it may go for volvulus also, or it may present as peptic ulcer disease, okay, that may bleed, that is the cause for the melena, or diverticulitis. If the whole diverticulum is patent, then even we can get fecal discharge from the umbilicus, especially in neonatal babies. What is this investigation you are seeing here in picture 2? This is what is called technetium 99 pertechnet scan. This is technetium 99 is concentrating in gastric mucosa in the stomach and in the ectopic gastric mucosa in the Meckel's diverticulum in right iliac fossa. That is diagnostic. See, you are seeing this is stomach. Because gastric mucosa, you are seeing the technetium is uptake is there. And you are seeing here also right iliac fossa, and this is bladder, excreted in the bladder. So this is the anterior view, this is the posterior view. If you are seeing the dye or the isotope technetium 99 in the right iliac fossa, that means probably it is a Meckel's diverticulum. Okay, how do they present, what investigation, and how will you treat this boy? You have to palpate the base of this diverticulum. His base is not thickened. You can go for this um, wedge resection, and you have to close it. No, you have to Heinke-Mikulis principle. You have to open it like this, and you have to close it like this. Yeah, not transversely. You have to close it vertically like this. Suppose if the base is thickened, then you have to do a limited resection like this, yeah, and end-to-end anastomosis. You have to resect this part along with the mesentery, and then you have to join this ileum with this ileum. Okay, end-to-end anastomosis. That is what you have to do. That based on whether the base is thickened or not. If there is thickening, that means it is having underlying gastric mucosa. Case number 10, this is a 70 years old man He has come to the hospital with complaints of pain abdomen, loss of weight, and early satiety. On examination, there is deep tenderness in epigastric area, but there is no mass. Patient is anemic and he is asthenic also, very cachexic. OGD picture is shown here. What are the findings in figure 1 and 2? What is the most probable diagnosis? You are seeing an ulceroproliferative growth in the antrum. Here also you are seeing a big tumor. So what is the diagnosis? What is the tumor? Most probably you have to prove the diagnosis by taking a biopsy, but it is a gastric carcinoma. What are the risk factors for this pathology? Positive family history, smoked meats and pickles, H. pylori infection causing atrophic gastritis, tobacco use, previous gastrectomy done before 10 years, blood group A, Menetrius disease, BRCA1 and BRCA2 and HER2 new genes. These are all risk factors. Figure 3 is showing CECT. You are seeing CECT. This is the stomach. You are seeing the thickness of the stomach wall. Thickness of the stomach wall. Treatment depends on number 1, staging and type of gastric cancer. There are 2 types of gastric, intestinal type and diffuse variety. Intestinal type treatment only I am telling it. If it is a diffuse variety, that is known as Lionitis plastica. Okay, if it is a Lionitis plastica, you have to do only radical total gastrectomy. If it is an intestinal variety and if the tumor is confined to the proximal gastric stomach, then you can do radical total gastrectomy with Roux-en-Y esophageal. If the tumor is confined to the distal gastric area, then you can do radical subtotal gastrectomy with gastrostomy. For all these cases, you have to do what is called D2 clearance for both these surgeries. What do you mean by this? Is the treatment summary in depending upon the stage. You can do curative treatment for stage 1, stage 2 and stage 3, but you can do only palliative treatment for stage 4. Okay, there are 16 lymph node stations. Okay, D1, D2, D3 and D4. The D1 is perigastric nodes, which is depicted in the green color here. So all these green color one are perigastric lymph nodes. This is also known as D1 station. D2 station is nodes around the main arterial trunks, which is depicted by the yellow color. So you have to remove only these nodes. Those who are shown in the green color and yellow color only you have to remove. You need not remove D3 and D4. So totally there are 16 lymph node stations. This is developed by the Japanese surgeons. Okay, because the CS stomach is more prevalent in Japan, so they are more advanced. But they are doing D3 clearance also. But you have to do D2 up to D2 clearance only. We have to do. What is the What is the post-op complications after this surgery? Patient may go for dumping syndrome, anastomotic leak, afferent limb syndrome, marginal ulcer, small bowel obstruction and internal hernia. These are all the post-op complications after gastrectomy. Coming to case number 11, 38-year-old female presented with upper abdominal pain and dyspepsia. OGD was done with which revealed antral gastritis. Flow test was done and findings are shown. You are seeing the findings for the flow test. What is the purpose of this test? What is the underlying reaction involved in this test? This flow test demonstrates presence of H. pylori in the mucosa of the stomach. The underlying reaction is the ability of the organism to hydrolyze urea with formation of ammonia. What are the other methods? Flow test is one method. This is urease kit test on gastric mucosal biopsy. You can do histology with Giemsa stains. You can do culture of H. pylori. You can do serological tests. You can do urea breath test. These are the other ways of proving the presence of H. pylori. What is the eradication treatment? Combined treatment, triple drug therapy, 1 PPI with 2 antibiotics, twice daily for 2 weeks. PPI like pantoprazole and 2 antibiotics like amoxicillin, clarithromycin or metronidazole. Eradication rates is around 90%. Why it is, what is the worrying condition this organism has been linked to? H. pylori is presently classified as class 1 carcinogen because of its association with CS stomach. So you have to eradicate the H. pylori infection.